And finally, I'm going to ask David Grossman to come up. David is a senior investigator, a pediatrician at Kaiser Permanente in Washington, and a senior medical director there for the Kaiser Permanente Medical Group. His research includes evaluating interventions to improve the uptake of preventive services. So that's what we're talking about today. He has an extensive background in injury prevention and control, as well as Native American health disparities research. Dr. Grossman is the immediate past chair of the U.S. Preventive Services Task Force, sponsored by ARC. This task force is an independent panel of experts that reviews clinical evidence and provides recommendations on a range of preventive services. So welcome, David, and we'll hand over to you.
Thank you very much, Terry. Thank you to the National Academies for sponsoring this event. We're excited at Kaiser Permanente to begin to use the learnings from this symposium and workshop to make a difference in our own healthcare system. So we're all listening, I think, very carefully. I'd like to, this panel is really around identification of risk, and I'd like to convey 6 points, which I believe will hopefully open up this discussion and get into some depth with a number of these. One is, I think it's a given that it's an imperative to understand, in order to be able to understand how to intervene with gun injury and death occurring to our patients. We need to know how to intervene at the right time. So we haven't really talked about timing yet, at the right place. And also with the right persons. And I think that much of this discussion will really focus on the third part around persons, but I don't want us to lose sight of the fact that timing and place are also critically important as we think about how to identify risk. The second point is that I think we're working under, and I want to be explicit about this, that we're working under the assumption that the prevalence of firearm ownership and access to firearms for the U.S. population is not going to change. So that firearms are likely to be a permanent part of our societal environment. I say that because it fixes one variable in the Haddon's matrix that Terry referred to, which is a critically important piece of our, it's foundational to the science of injury control, which is that we're not likely to have changes, at least in that environment. There could be changes and nuances in that, but for the most part, as we think through identification of risk, we have to be thinking that the overall presence in society is not going to change, at least in the foreseeable future. The third point is that firearm injury, for many of us that have worked I used to work in the trauma healthcare system prior to Kaiser Permanente, and obviously ER docs and many people working in trauma systems that are represented here, I think we have to remember that despite that firearm injury, because it affects younger people disproportionately, by definition, given that there aren't a lot of other, by definition, is still a relatively rare outcome in absolute terms. So that as we think about identification of risk, it is a little bit about finding the needle in the haystack as we attempt to identify who those potential victims are. So it makes discrimination in the science of risk prediction more complicated than perhaps for more highly prevalent causes of mortality, particularly in older people. The fourth point I want to make is that I think that targeted interventions make sense to the extent that we really understand to whom we should direct those interventions. The more precisely we can target to people, the more effective and the more efficient we can be. Again, I'm making something more explicit about something that I think was more implicit in the previous discussion, which is, yeah, it's all about risk prediction and finding the right people. There are universal interventions that could be deployed. In pediatrics is a good example where every child is universally screened for presence of firearms in the home and then advice given. That's a universal intervention, as opposed to screening and targeted interventions, which I think has been dominating the conversation so far. The fifth point is clearly an important evidence gap here is that we face is to help clinicians identify people who would benefit from an intervention designed to reduce the risk of injury. So, and when I say that, it means that we need to make it easy for clinicians to do this. We have a long trail of screening instruments and complicated tools that clinicians have never really figured out how to use, and even simple ones that are now being used for depression screening still have not been widely implemented. So part of the process here is not only the science of understanding what's the right thing to do, but also how to implement it and make it easy to do, using both the best evidence and both in terms of screening tools as well as, or risk prediction tools, as well as the right interventions. And then the sixth and my final point is I think that building on that, we have to use state-of-the-art risk prediction tool methodology as we do for other clinical outcomes. This was alluded to in the previous session. We use sophisticated algorithms that are multivariate based for prediction of risk of cardiac events or cardiovascular events, as we do with the Framingham or pooled risk equations. We use FRAX to identify who's at risk for osteoporosis. We use BRCA Pro and other breast cancer screening, breast cancer tools to be able to do risk prediction for who's at risk for breast cancer. These are tools that have been developed to address a wide variety of clinical conditions and that have been carefully honed to understand both our ability to accurately predict risk, but understanding that in any time you're doing risk prediction and interventions, there's always a potential for adverse outcomes and adverse effects. To the extent that we can improve the accuracy and the discrimination of those tools, we'll be much better off. I think that my work with the U.S. Permanent Surface Task Force has taught me that that's not easy, in part because the funding for that type of work has largely fallen to the dominant causes of mortality in heart disease, in cancer. But I do think in the realm of mental health and building on the work that many have done, and my colleague Greg Simon here from my own research institute with his Mental Health Services Research Network, there is an opportunity actually to extend some of that work to do multivariate modeling to be able to better predict who's at risk for a firearm injury. Thank you.
Thank you, David.